Okay, there's the title. We can go to the next page. This is just obligatory. We can go to the next page. Okay, BPSD. This is kind of shorthand for all the different symptoms that occur in setting of dementia that are of greatest concern. So a lot of people think of yelling or aggression or different things like that, but it encompasses a lot of different things, and I included a lot of them right here. This is from one of the papers that includes an algorithm that we'll be talking about in just a second, but we can go ahead and go to the next slide. Okay, so we've established an algorithm at my clinic from two different algorithms. So one is from the International Psychogeriatrics Association, which was published in 2024. And the second is from a program at Harvard University. They identified it as South Shore. That was published in 2021. So the first line recommendations are to decrease to make non-pharmacologic interventions. So the first thing is to decrease anticholinergic burden. If you're not sure what I mean about that, go to abccalc.com. So that's or acbcalc.com. That's anticholinergic burden calculator. And basically, different medications can block exchange of acetylcholine at neurons. And so that can worsen a lot of different symptoms, especially in the setting of Alzheimer's dementia. So decreasing anticholinergic burden is a good idea. Medications with high anticholinergic burden include like first generation antihistamines like diphenhydramine, Benadryl, medications used for urinary symptoms like oxybutynin, things like that. The next thing on the list is to optimize treatment for dementia. So that's a cholinesterase inhibitor. The most common one that's prescribed is usually donepezil, but we'll talk about this a little bit more in a second. And then another one that's often prescribed is memantine. The third thing is to optimize sleep and nocturnal circadian rhythm agitation. So they recommend trazodone. I put an asterisk next to it because I'm kind of like, yeah, you could use trazodone, but what I see is trazodone just gets prescribed for everyone every time there's any sort of slight concern for sleep at night. And we should really put a little bit more thought into it than this. So first of all, there's no evidence that trazodone does a whole lot to help with sleep, especially in the setting of dementia. And if you look into it a little bit deeper, what you find is the general consensus is, well, you can try trazodone because we've done it forever. There's not even a good study that says that it works well in dementia patients. It's just we've suggested a sleep medication that doesn't seem to be nearly as bad as Ambien. So one thing that we do know is regular use of trazodone does not seem to be very beneficial. And another thing that we know is doses greater than 50 milligrams don't seem to improve sleep, but are associated with more side effects. So the lowest strength trazodone you can purchase is 50 milligrams. So if you need more than that, it might not be a good idea to keep going higher. The next thing is some say dual orexin receptor antagonists, so like Belsomra. They claim that those are appropriate in setting of Alzheimer's. I strongly disagree. I think that they misinterpreted their data and did things wrong in their study. We talked about this a little bit last month, so I won't dive into it real deep, but essentially they grouped a group of people that they think had Alzheimer's disease and tested this out on them, and they had them hooked up to sleep monitors. First of all, most of the patients that I've met that have Alzheimer's dementia and struggle with sleep and agitation wouldn't tolerate laying with a sleep monitor. Secondly, in the group that was greater than 65 years of age, so the group that was more likely to have Alzheimer's, there was no benefit identified. Next, the group that had ApoE4 homozygous alleles, so that group is more likely to have Alzheimer's, saw no benefit. And those with lower MoCA scores, they didn't see any benefit. So people who are most likely to have Alzheimer's, they didn't see any benefit. And I think there's too many side effects associated with sleep medications like Belsomra to recommend that. Okay, next page. Okay, so now we're getting to what are the next steps for medications. So regarding citalopram, which is the first line recommendation I have here. So this recommendation here comes from what's called the CIT-AD trial, so CIT-AD. And it identified the greatest benefit was when the dose was 30 milligrams daily. So the current recommendation for older adults is not to exceed 20 milligrams daily due to an increased risk for arrhythmia, likely due to QT prolongation, which occurs with citalopram. The risk for QT prolongation in arrhythmia is remarkably small, but it seems like all providers seem to know about it now. But if there is a desire to exceed 20 milligrams, it would probably be a good idea to get an EKG first and look at the QT interval. And if it's greater than like 480 milliseconds, it might not be a good idea to increase it further. But that is the medication. I mean, to be honest, citalopram is the SSRI that has the most evidence for benefits, and it seems to need those higher doses to really get good benefit. Second line recommendation I have here is S-citalopram. So S-citalopram is just the S isomer of citalopram. So citalopram is a racemic mixture of both of the right-handed and the left-handed versions. And this is just S-citalopram is just the one-handed. So a 20 milligram dose of S-citalopram is equal to citalopram 40 milligrams. There's a few more rules around that. S-citalopram has not been studied as extensively as citalopram, but most experts do agree that you can basically consider it as a surrogate for citalopram, although citalopram is still the gold standard. The third line is sertraline. There's no great evidence for benefit for use in those with dementia. In general, it has evidence for benefit for anxiety and depression in older adults, but not necessarily for those with dementia. So if for some reason citalopram and S-citalopram are not options, you could consider sertraline. Okay, let's go to the next slide. Now we're getting into more dangerous medications. So if you're not aware, antipsychotics carry a black box warning for increased death for use in setting of dementia. This is a pretty broad labeling that occurred from the FDA in the late 2000s, essentially. And a lot of this, I mean, I don't know exactly what all went into it, but the general story goes, for those who were in nursing homes, basically you want to calm them down as much as you can. So everybody was getting antipsychotics, and then they went and looked at it and were like, oh gosh, this is a terrible idea. So now it's not recommended to give this to everyone, which is why we have these algorithms to try and make things safer. But what I want to talk about here is there are some, not all antipsychotics are created equally for this kind of treatment. And so which ones would be best to choose? So regarding risperidone, this is our first line antipsychotic that we use. This medication has the best evidence for benefits after optimizations of the previous steps that we just talked about. It is still an antipsychotic and still carries that black box warning. So we reserve it for those who are a danger to themselves or others. Risperidone is the preferred antipsychotic for agitation in dementia in Canada and Australia. So although it doesn't have that FDA label here, there are other countries that are very similar to ours that do have this approval. The second line is aripiprazole. It also has good evidence for benefit. We don't use this one as often in our clinic, but it could be appropriate. Regarding olanzapine, it has weaker evidence for benefits, and it's likely due to the fact that olanzapine tends to cause a lot more side effects than risperidone and aripiprazole. And so if you cause more side effects, it's probably not going to turn out quite as well with the results. Regarding brexpiprazole, so this is also called Rexulti. You can see commercials for it on TV right now. Basically, the commercials say, if you put your grandma on this, now you can take her out antiquing and there won't be any more problems. Their evidence for benefit exists. It's not super strong, but they were the first medication to get approval for treatment of agitation in the setting of Alzheimer's like dementia. They claim that if you use anything else, it's irresponsible. I strongly disagree with that. It's hard to say that it is better than risperidone or aripiprazole because they only complain they compared themselves to placebo. But the main thing that matters here is Rexulti might be a perfectly useful drug for people, but no one can afford it. I have yet to meet anyone who can afford this medication because the brand name price is, $1,000 per month. Because of that, we just don't even consider it an option, and that's where we start with risperidone. Plus, we don't even know that Rexulti, like I said before, that it's better than risperidone because they didn't compare them against one another. After that, now we get to a little bit more exotic kind of things. So prazosin is on this list. You might know prazosin as it's a medication that often gets prescribed for PTSD people to help reduce nightmares at night. We don't have a lot of experience with prescribing this in our clinic, but it is the next one on the algorithm to try. The next one after that are anticonvulsants, so anti-seizure medications. Carbamazepine is on the list, and from our psych provider from last year, she said oxcarbazepine is also an option, as is gabapentin. Again, these are further down the list of recommendations, even after you've optimized like the antipsychotics. So these are not ones to go to before. After that, now we have Nuedexta, which is a medication that essentially no one can afford, and Nabilone, which no one can afford. So they're on the algorithm, no one can afford them, so we're going to skip over them. All right, next page, please. Okay, we have a patient here. This is a case, 83-year-old female, moderate dementia. They're requesting a refill of her opioid. Here's her pertinent medication list. So Tylenol PM every evening. So the PM part, of course, is going to be a concern. Lexapro every day. Gabapentin nightly that she's taking most nights, as well as hydrocodone, acetaminophen, and then naproxen that she's taking sometimes. So the opioid had been started for cancer pain at one point. But oncology recently stopped filling it. So we recommended to stop the Tylenol PM, start scheduled Tylenol, consider an SNRI to replace Lexapro. Maybe that would help with pain a little bit, and identify the lowest effective gabapentin because maybe that's causing some confusion. At the follow-up, we were told that the PCP who had taken over prescription of the hydrocodone was not happy with our recommendation because we had, quote, discontinued hydrocodone acetaminophen. Actually, we did not discontinue it. The opioid just wasn't refilled, so we were trying to fill in the goal or fill in the gaps. Let's see. Now the patient is taking hydrocodone acetaminophen 3 times daily, so now she's taking it even more than before. And the son emphasized that the PCP said that pain is under-recognized in those with dementia, and so we have to make sure we cover the pain. So this is really wanted to get to is pain undertreated in those with dementia? I would disagree with the provider's premise. It can be under-recognized, and we should think about it. However, oftentimes I think it's actually over-treated because when a patient comes into a clinic, they're asked what is their pain score. If you're not good at subtracting numbers, which is something that we do in the MOCA, or thinking of different things like that, it can be extremely difficult to quantify your pain on a number scale. In addition, one thing that I find is people who have had chronic pain or have a reason to have pain, it's often a first thing that people discuss with them. Like, my grandma is struggling with pain. And so, Grandma, how are you doing today? Is your hip okay? Starting conversations like that kind of plants that seed that pain is a problem. We've seen many patients who had chronic pain and were on chronic opioids. As they progress in dementia, they no longer need the opioids anymore, suggesting that there might be an emotional component there that now has kind of disappeared. It's hard to hold on to that thought that the pain is there. So it should not be dismissed, though. There might actually be pain there. But also, one thing to keep in mind is dementia patients, they might lack the ability to care for the pain anymore. And so one example that Dr. Kuntz has used with me is, let's say we're sitting there watching TV, which is not an uncommon thing to do in our dementia patients, and you're sitting there for a long time and now your hip starts to hurt. What do? Well, you kind of shift positions on the couch to a different position, right? You might lack that ability to recall that, and you just kind of sit there and just sit in your pain, and people keep asking you about your pain, and you're not getting up, walking around the things that you should be doing. So there's a lot of different aspects to pain. I'm not saying that dementia patients don't have pain, but I really worry that sometimes we overtreat it because it's just the thing that we talk about, especially when we come to doctor's offices. So let's go ahead and go on to the next page real quick. So one thing that I want to encourage people to do is not dismiss the pain, but to question the pain and ask a few more questions about it, right? So we've had patients that were even signed up to go get back surgeries, and we asked them to hop up on the table to do an examination, and they hop right up there. No problem. This isn't an issue. But if you start to ask questions about their back pain, they're like, oh, I can't do anything. I can't do anything. And so we've learned that sometimes if you talk about pain, you're planting the seed and making kind of building off something that may not actually be there. And my main concern is the medications that we use that are strong for pain, like hydrocodone, gabapentin, other opioids, even tramadol. They have real side effects, including affecting cognition and making that worse. So we want to try and minimize the harm that we're providing. And so we try and educate caregivers to redirect, like, can you get them to talk about something else and maybe the pain goes away? Or can we use acetaminophen around the clock and use that for treatment of pain instead of the Norcos so that we can try and optimize the safer things first? Can you go on to the next page for me, Lindsay? Okay, the next one is sleep worsens cognition. So should we use a medication for sleep? So for this patient, the patient's family is requesting medications for sleep because she is up a lot at night. She sleeps all day. The patient disagrees with this statement, which resulted in an argument between family members. But we know that while we know that poor sleep affects cognition, there are no medications for sleep that have been identified to improve sleep and cognition. All medications for sleep are associated with an increased risk for daytime sedation, like a hangover effect, falls, and confusion. In nearly all cases, we identify a correctable issue, like this patient is sleeping during the day. So we have found that many people will deny that they sleep during the day, but family members will point out that they, quote, doze, which is apparently different than a nap, but I'm not sure. And then also, it is very unlikely that a person can sit in front of a TV all day and not fall asleep at some point. So we also find that a lot of people are already getting adequate sleep at night. We'll ask them what time they're going to bed and what time they're getting up. And it's not uncommon that they're getting more than enough sleep at night, like 6, 7, 8. We had one guy that asked for sleep medicine, but he was in bed from 10 at night till 10 in the morning. He felt like he needed a sleep medicine because he was still tired during the day. And so it's important to ask those questions, because is it truly like you're not sleeping at night, or is it because you're tired the next day? And giving a sleep medication could actually make all of that worse. It is also common, let's see here. We have had multiple patients say that they are in bed for 10 hours, and they tend to believe this because they are tired the next day, that they need more medications. And so can you go on to the next page real quick? So our recommendations were to minimize daytime napping and try and get some activity during the day. I have a feeling that when people come into our doctor's offices during the day, they usually sleep pretty well that night because there's been a lot of activity that day. And then regarding sleep medications, this pharmacist believes that the risk probably outweighs the benefit for all of that. Optimize bedtime ritual. So find something. So what I mean by ritual is, whether we realize it or not, when we get ready for bed at night, we all have a routine that we do, brush our teeth, put on our pajamas, pull the sheets down, different things like that. If you're out of that ritual, like let's say you're on vacation, that's a good example of something different happening. Or you have a new puppy running around your house, that can really throw you out of ritual. That can really disturb sleep a lot. So trying to optimize our ritual, and sometimes that incorporates things that make us happy. So some people like sleepy time tea or warm milk. There's something kind to do to yourself that kind of helps you relax as you're getting ready for bed. And then I see also in the chat, obstructive sleep apnea question mark. That is a great idea. So of course, anyone who struggles with fatigue during the day, sleep at night, from a pharmacist standpoint, I encourage that to be optimized, but I think it should be evaluated by other providers. Okay, Next one, please. Okay, this is an interesting case that happened to us. So we received a phone call from a patient's husband. He and the patient, as well as another couple, traveled out of state. During the night at the hotel, she became disoriented. She has pretty advanced dementia, and she didn't recognize him. She assaulted him during the night and had to be returned to her room more than once in the night, typically with the help of the other couple that were traveling with them. He is wondering, so now that they're in another state, he is wondering if there are any medications that we can prescribe to calm her down. So the initial request was, can the provider prescribe a medication to get her on the plane? Then it was changed to they were going to drive back to Idaho in a rental car that would take over 12 hours. So what do we do then? So regarding potential medications, if possible, I would recommend to try and avoid any as needed medications due to high risk for all medications that try and calm down the brain run the risk of escalating delirium and agitation, especially if she's already in a delirium state. And so, especially the fact that they have to try and move her through public places and stuff like that, it could make things a lot worse. As a pharmacist who's looked at this for a long time, if you were going to try anything, which I'll tell you what we did here in a second, but if you were going to try anything, you could try trazodone at like 25 or 50 milligrams, or in a severe case, it could be olanzapine 5 milligrams. I strongly recommend against any benzodiazepine, so that's like Xanax, Valium, something like that. I would strongly recommend against antihistamines like Benadryl, doxylamine, hydroxyzine, or skeletal muscle relaxants. So go ahead and go on to the next page. So I actually wasn't available when all this first went down, and then our social worker wasn't talking to him. So in the car, it was decided that the husband would drive and the patient would sit on the opposite side of the car in the back seat as far away from him as possible. We also encouraged them to turn on the child locks to prevent the patient from leaving the car on her own. And the other woman that was sitting in the back with her to have distractions ready, like snacks, movies, calming music, books. And if they need to, they could contact the Alzheimer's Association crisis hotline for additional ideas. They, just so you know, to wrap up this story, they did make it back home. And again, that night, once they were back in their home, she beat him up again because she didn't recognize who he was. And then he found her placement out of memory care. All right, this last patient, I just want to go ahead and pull up the next one. So I'm just going to talk about this one real quick. So remember when I was talking earlier about we need to optimize the Alzheimer's medications first before we do anything else. So we have this patient that we had met with for several years, and she came to us on donepezil. So you can see donepezil 10 milligrams daily, memantine 5 milligrams twice daily, and sertraline 50 milligrams daily. And she had a history of struggling with anxiety, agitation, had been prescribed diazepam at bedtime even. So at one point in September of 2024, she got sick to her stomach, I think it was. She was upset about some stuff, and she's like, I want to stop all my medicines. So the family, even though we had talked to her multiple times about possibly stopping donepezil, she was like, now I'm ready. And so we helped work with the family to do this safely, so we keep some medicines on, and she wasn't going to go withdrawals by stopping a bunch of different medications. So we kind of worked on that. And so we tapered and stopped donepezil over a course of 2 weeks. And we actually had heard from this family at least monthly for a long time. It went several months without hearing from her. So that all occurred in September 2024. Then in January 2025, the patient found an old bottle of donepezil and wanted to know why she wasn't still on that medication. Her husband couldn't recall, so he gave us a call. And so I reminded the husband about everything they had struggled with, the anxiety, the agitation, the nausea, different things like that. And no one really thought donepezil was helping her, so that's why we had stopped it. And he said, oh yeah, I remember that conversation now. And he added, over the past few months, that she seemed much more calm. The loose stools had ceased. And so through our discussion with him, I advised him to throw away the bottle because out of sight, out of mind, we don't need to be on that anymore. But this kind of factors into, if you're going to try someone on donepezil, be aware of what happens. Are they getting benefits? Because most people don't get benefit on that medicine. And a lot of people get side effects. And if we're making people's lives worse by putting them on a medicine that's supposed to be helping memory, then you could cause a lot more agitation and hardship and stuff like that. And so yes, you should optimize Alzheimer's medications, but it doesn't mean that you have to keep it going forever and ever because it might be causing more problems. Okay, last slide. I went through this algorithm. On one of those previous pages, I gave you the references for the two algorithms that we use to help compose this. What's not on this algorithm? And here's a list of things that are not on this algorithm, but I see a lot of. And so I just want to hit on some of these. And some of these, I'm not saying you can't ever use these for these patients, but they should not be your standard go-to first line kind of stuff. So benzodiazepines, they are almost a bad idea all the time in people with advanced Alzheimer's or moderate degree Alzheimer's. Most antipsychotics have been evaluated to see if they help with agitation in the setting of Alzheimer's. And that's actually what we got down to. Risperidone, aripiprazole, olanzapine, and brexpiprazole is most of them didn't work or they made symptoms worse. And so the antipsychotic I probably see the most is quetiapine. And yet the reviews on it are mixed at best. And for a lot of people, it didn't seem to help. There are some people for whom quetiapine would be a good idea, like those who have Parkinson's or Lewy body dementia. They could be using them, but not for those with like Alzheimer's type. Depakote, it's been tried for way too long now without any good benefit. So unless they have bipolar, it's probably not a good idea to put them on that. Hydroxyzine has high anticholinergic burden. Hormones. Hormones have gotten extremely popular to help with memory. Testosterone, estrogens, they're not a good idea. I even saw someone a few weeks ago who was on the Medrol injections, the depot, Medrol depot injections to try and, or I can't remember the name of it now. The progesterone injections to help decrease his hypersexuality, that's been studied. It didn't work. You don't have to give people injections to try and knock that down. Mirtazapine is not a terrible idea for some people who have anxiety, but it just hasn't been beneficial for BPSD. Clonidine, I have very high risk for falls, especially for older people, and so there's a huge risk there. Sleep medications, I mean, anything that shuts down your brain will increase your risk for confusion and falls. Stimulants, I see a lot of people getting put on stimulants because maybe they have some form of ADHD or maybe it's the fatigue. I think one thing that all providers should be aware of is if a person seems to be more depressed in the setting of dementia, yes, they might be depressed, but it might also be that they're having a hard time forming thoughts to be able to do the things that they used to enjoy. And so them not enjoying doing the things they used to enjoy does not mean that they need a stimulant to get going. It means they might need a caregiver to help get them going in that direction. Wellbutrin, I'm going to skip over Alvelti real quick, and then skeletal muscle relaxants, and then other SSRIs. One last thing, that Alvelti, I made this presentation within the last month. I think 3 days ago, the FDA came out that Alvelti can now be used for agitation in setting of Alzheimer's dementia. It's the second one after Rexulti to get approved. I do not recommend using it yet. I tried to find data on the benefits and the risks associated with this, and I could find none in setting of dementia. And I do know of at least one patient that we have, and we believe that it's Alzheimer's dementia that she has, that did get put on this, and she spent a couple days on the floor because it made her so sick. So the only thing I could find from the FDA announcement was a reference to the company that owns Alvelti saying how wonderful it is and you should give it to your people. But I couldn't find a publication. I couldn't find side effects profile. I couldn't find different things like that. And so I just am not comfortable with it yet. But just so you know, that is now approved. Okay, that's everything. I know I went a little bit long. Is there any questions?
Great job, Jeremy. We'll have time for a couple questions. You can unmute and ask those directly or put those in the chat. And thanks for that most recent up-to-date information that you wove in at the end.
I was so disappointed when I saw that. I'm like, no, it's finalized. I already sent it to Lindsay.
So I was just curious about what other community resources are out there for folks besides saying all the meds are bad, don't use your meds, and go to alz.org. What else are you using?
Are you talking about for like agitation?
Yeah, I mean, someone gets more, to this, their slums are dropping down closer to 10. They're getting
Mhm.
agitation. They're losing that frontal lobe inhibition. They're acting out. They may not be wondering, but just a lot of aggression, and they're getting very difficult to live with. They need some help with occasional basic, ADLs or IADLs or shot.
Yeah.
They're not quite ready for memory care or don't have money for memory care. They need help, but we're saying most of these meds you should avoid. So, what resources are you giving them in place of the meds?
So, I mean, speaking from medication point specifically, like we will optimize. So by that point, they've probably already been on Alzheimer or donepezil and or memantine, so they might or might not be on there. And then we'll end up optimizing the SSRI, probably Lexapro, maybe citalopram. And then after that, we start risperidone. And by that point, I mean, the nice thing is in our clinic, like there's me, and then there's our social worker, and so there's a lot of coordination trying to help families understand how to interact with the patient differently, or try and get them connected with what needs to happen next, like if they need to go live in a facility or something like that. But basically, I help out with like the dosing of the risperidone and the other medications like that. So yes, it has a black box warning. Yes, it's not a recommended first line, but there is evidence that it can help.
Yeah, so I think Jeremy's saying it's a yes and approach, right? That parallel path with caregiver support and education, identifying non-pharmacologic interventions that can help, like identifying triggers, reducing triggers, teaching calming and de-escalating techniques to family members. We offer that support in our clinic and engage community partners like PT, OT, ST to help teach those skills. And a lot of connection to family caregivers, to classes. There's an improv to improve dementia care class in town that we refer a lot of people to that teaches these de-escalating techniques. The example Jeremy gave of the individual traveling across country, that family was given hours of education over the phone by our social work team on how to de-escalate the situation in the car, and they did have a successful trip in the car back, even though when they got back, she was again triggered by something in the home and ultimately determined not to be safe to continue at home despite pharmacologic and non-pharmacologic interventions. But it takes the whole approach, right? The both, often in these cases, the meds and the non-medication interventions.
Thank you. There's some great additional information in the chat. Christine, let's go to you. If you could let us know what your role is. We'll have Christine's question, and then I'm going to move quickly to our case so we have time for our case today.
So I do inpatient, outpatient teaching of medical students at ICOM, family medicine. So I guess mine was a follow-up to Dr. Crownover. I know you're talking a lot about clinic management, but what about in the hospital when we have agitation? Neurology does recommend Seroquel. Sometimes you're saying no, so.
Right. So I would recommend looking at those two references because they talk about, at least one of them, but I think both of them talk about inpatient care as well. And I'm going to see if Dr. Desai wants to respond to this one since he is part of our inpatient team that helps recommend this. And I have seen him recommend quetiapine as well. And so I'm not saying that it can't be used, but there is something that these experts like Dr. Desai see that makes it a different kind of answer than following the algorithm for the majority of patients.
Right. Yeah.
So I would echo Jeremy that if you have to just answer quickly, then don't use quetiapine. All these antipsychotics have to be used for the right person at the right time, at the right dose, for the right duration, looking at neurological comorbidity, medical comorbidity. So the complexity just skyrockets. And there's a good chance we will do more harm than good. So there is tremendous push in the hospital from the staff for the physicians to give something. We are fortunate at St. Ives that we have a G60 program which addresses dementia, delirium, and we have a nurse practitioner. But if I had to pick something, I would say really assess detailed what causes the problem and then address the cause, which many times is boredom and pain and stuff like that. Thanks.